Okay, so this next slide is on the different forms of dialysis. So the two forms that are used are peritoneal dialysis and hemodialysis. So peritoneal dialysis can be easier, especially if you live far away from a hospital, since this can be done at home. Hemodialysis tends to require 3 visits to a hospital or a dialysis unit, and typically to stay there for about 4 or 5 hours to have your blood dialyzed. Okay, so let's go back to peritoneal dialysis. How does that work? So a dialysis solution is instilled through a shunt that you have in your abdominal wall into the peritoneal cavity. And the fluid sits there and it gradually pulls waste products out of the bloodstream. So it's going to pull out all the body's waste that's circulating through the blood, and it'll also pull out electrolytes. So it'll try to control the electrolyte levels in the bloodstream, and it will sit there for hours, and then the solution is changed. Okay, so it's a process that can be done at home. Sometimes the process is done overnight, so patients will instill the dialysis solution overnight and then remove it in the morning. It's still a time-consuming commitment, but it allows people to stay home. Hemodialysis, typically the patients go to a clinic or a hospital and they have a shunt in their arm. So it's called an AV shunt, an arteriovenous shunt. A needle is put into the AV shunt that attaches to a large hemodialysis unit, and it removes excessive fluid because your kidneys haven't been removing fluid. So the machine removes excessive fluid. It will remove waste products from your blood, and it basically acts as your kidneys. And this typically needs to be done 3 times per week. And what the machine basically does is it restores your overall fluid balance and electrolyte balance. Now, you still need to be careful with all of those dietary restrictions that we spoke about. Plus, the one that we didn't mention is the amount of fluids you can drink, right? So if you're on dialysis, you can't consume tremendous amounts of fluid every day. There's nowhere for it to go, right? The kidneys aren't acting as your filter. So patients on dialysis need to be careful with their overall fluid intake daily. Okay, so let's do this question together. Which of the following renal disorders is characterized by increased BUN and creatinine levels? So acute kidney injury, whether it's pre-renal, renal, or post-renal, the kidney is being injured, the nephrons aren't functioning normally. Typically it's temporary until the condition has been treated. So if it's pre-renal, it's fluid administration. If it's a renal issue, it depends on which renal issue it is there's a treatment that needs to be given. And if it's post-renal, the obstruction needs to be relieved. But definitely with acute kidney injury, you'll have elevated BUN and creatinine. Glomerulonephritis, which is inflammation of the glomerulus, causing leakage of protein and cells into the nephron and harm to the glomeruli, right? So And with glomerulonephritis, your glomerular filtration rate declines until treatment is given to try and improve the glomerulonephritis. So your BUN and creatinine will definitely be elevated. Pyelonephritis is typically a bacterial infection of one kidney. So we wouldn't expect your BUN and creatinine to be elevated because one kidney is infected with bacteria, which of course needs antibiotics, but the other kidney is still functioning normally, and you can easily maintain a normal BUN and creatinine with one kidney. Okay, so when patients donate a kidney and they have one remaining kidney, that is more than enough filtration to maintain the body in terms of all the functions of the kidney, and also you would still have a normal BUN and creatinine in the bloodstream. So pyelonephritis wouldn't cause an elevation of BUN and creatinine. Chronic renal failure or chronic kidney disease, which are really the same term. So that's a decline in overall nephrons in the kidneys, whether it's due to hypertension or diabetes or some other process that has chronically harmed the kidney. That will definitely elevate the BUN and creatinine. So it would be A, B, and D as the answer. Okay, let's just briefly talk about polycystic kidney disease. So this is an inherited disorder, and it's inherited in an autosomal dominant way, meaning really just one of your parents need to have this condition for you to potentially inherit it, right? So you just need one allele from one of your parents, and if it's the disordered allele or the affected allele, you now have the condition. So autosomal dominant. And basically it results in hundreds and hundreds of cysts that have formed on the kidneys. So polycystic kidney disease. And these cysts can develop in other organs as well, such as the liver. But really what happens is a deterioration in kidney function that due to all these cysts on the kidney and the reduced number of nephrons. So it typically leads to hypertension and loss of renal function. So chronic kidney disease, right? And often when someone with polycystic kidney disease is being examined, you can actually feel these enlarged kidneys on palpation of the abdomen, because the kidneys are enlarged, and there's often very large cysts that are coming off the kidney. So often on palpation you can actually feel polycystic kidney disease. So how do we diagnose someone with polycystic kidney disease? Well, it can be from a variety of different presentations. So someone might present with flank pain, and we end up doing an ultrasound that then shows these polycystic kidneys. They might have a family history of polycystic kidney disease since it's an inherited disorder. They might come in and describe an incident of hematuria, because some of these cysts have ruptured or bled, and they now have hematuria in the urine. They may have abnormal BUN creatinine on blood testing, right? And then that leads to an ultrasound of the kidneys that then leads to a diagnosis of polycystic kidney disease, right? So a number of different ways that lead to the diagnosis. And the main issue is the very high blood pressure that needs to be controlled because the kidneys are failing. These cysts can become infected, so they can get on top of having all these cysts and very weak kidneys, they can get infections of the cysts because they're fluid filled, right? So that's a big issue as well. You can have ongoing bleeding in your urine, which can be an issue, and of course just gradually declining renal function and declining GFR, right? So typically it results in dialysis, whether it's peritoneal dialysis or hemodialysis. That's the end result of most patients having polycystic kidney disease. Okay, so let's just chat about bladder cancer next. And bladder cancer is the most common urological cancer. So if we're thinking of kidney cancer and bladder cancer as the two cancers of the urological system, bladder cancer is the most common, okay? And we call it a transitional cell carcinoma. So the cells in the bladder are called transitional cells, and we develop carcinomas from them. And they make up about 80 to 90% of genitourinary cancers. Definitely more common in men than women, and we'll come back to that in a minute. And often it's related to environmental exposure. And definitely the number one cause, cigarette smoking. Okay, and we'll come back to that in a minute. So you can also have it from diesel exhaust exposure, petroleums if you work in an oil factory. So a lot of chemicals that can get into the bloodstream that finally land up in the bladder, in the urine. There are a couple of genetic disorders that can cause it, but really the main one to think of is chemical exposure, and in particular cigarettes exposure. So cigarettes don't only go into your lungs, right? The fumes of cigarettes don't only go into your lungs and put you at risk for COPD and lung cancer. You swallow a lot of the carcinogens in the cigarette smoke. And so that's why it puts you at risk for stomach cancer, pancreatic cancer, and of course your bloodstream absorbs these carcinogens and they circulate throughout your body, which leads to arterial disease, right? So atherosclerosis of the arteries, blockages of arteries to your heart and your brain and your legs. And finally, the carcinogens get filtered, so that puts you at risk for kidney cancer and at risk for bladder cancer. So why would it be more common in males? Well, in general, over the years, men tended to smoke more than women. That's not necessarily the case any longer. So likely women will catch up in terms of the incidence of bladder cancer versus men. But men tended to be smokers and also be exposed to more of these fumes and chemicals than women. So what's the main symptom of bladder cancer? Well, it's painless hematuria. So somebody that comes in and says, I'm just peeing blood. Now, could that be other things as well? Absolutely, right? It could be just a simple urine infection. It could be a kidney cancer that's bleeding and sending blood down to the bladder, and then you're urinating blood. So, but the classic presentation of bladder cancer would be someone who's been a long-term smoker, and now they come in and present with gross hematuria. Okay, and when we say gross hematuria, we mean the word gross, meaning we can see the blood with our eyes, as opposed to microscopic hematuria, which is blood that you can't see with your eyes, but our urinalysis on the dipstick can pick up the blood. Okay, So really the diagnosis of bladder cancer is with cystoscopy, a scope that goes into the bladder to look at the bladder wall. Okay, so typically if someone comes in with hematuria, so bloody urine, we're going to check to see if it's a simple infection, because if it is, we'll just treat it with antibiotics. If it's not, then we need to look in two areas. We need to look in the bladder, and that's with a cystoscopy, and we need to look at the kidneys, and that's typically with an ultrasound or a CAT scan. Okay, so because those are the two sites where a cancer could be occurring, bladder or kidney. And remember, both of those cancers occur much more frequently if you're a smoker. Okay, so last slide here, let's talk about urinary incontinence. Okay, and there's different types of urinary incontinence based on what's occurring. So the first one we're going to talk about is stress incontinence, meaning as your bladder fills with urine, the valve, which is at the bottom of the bladder, isn't strong enough anymore to hold the filling bladder. So you start to leak, right? So who is going to get stress incontinence? It's typically going to be someone who's had multiple pregnancies. And why is that? Because the tissue has been stretched with deliveries and they don't return back completely to normal. And so now what happens is, as the bladder fills with urine, the valve is unable to hold the increasing pressure, and with coughing or sneezing or any other kind of intra-abdominal pressure, such as straining or lifting, you actually leak urine. Okay, so much more common in females, much more common in a female who's had multiple pregnancies. Okay, and it's really due to the pelvic muscles that have become deconditioned or potentially injured during delivery. Okay, so there's definitely exercises, they're called Kegel exercises for stress incontinence, to strengthen the pelvic muscle floor. Okay, so this is a very common type of incontinence in your 40s, 50s, 60s, and it's all due to that weak valve, okay, and any kind of increased abdominal pressure. Okay, what about urge incontinence, or an overactive bladder, or what we call an irritable bladder? So sometimes the muscle of the bladder just doesn't want to cooperate with stretching as the bladder fills with urine, because that's what the muscle's supposed to do, right? It gradually stretches and gets bigger and bigger and bigger as the bladder fills with urine, because really the function of the bladder is to hold urine. And if you have an irritable bladder or an overactive bladder, then what we're really referring to is that the detrusor muscles suddenly just start to contract and they're overactive. So it's really unpredictable because someone with urge incontinence can suddenly just have the sensation of having to go to the washroom, or they're going to be incontinent. Okay, so it makes it a bit of an uncomfortable situation when someone's walking down the street, say with a group of friends, and suddenly they have the overwhelming urge to urinate, and if they don't get to a washroom quickly, they will have urge incontinence, and it all has to do with the irritable detrusor muscles that suddenly start to contract. Okay, and often patients will come in and say, I suddenly get this urge, to urinate and I have a minute to get to the washroom, and if I don't get there in time, I'm incontinent. Okay? And there's medications we can use to try and relax the detrusor muscle of the bladder. Okay? And that's really what we use. Medications to cause bladder muscle relaxation so that they're not getting these sudden urges to go to the washroom. And again, that's much more common in women. Okay, so stress incontinence, more common in women. Urge incontinence, again, more common in women. And we're not talking about anything that has an infection here, okay? The first one, the stress incontinence, is related to a weak valve, and the overactive or urge incontinence is related to an irritable bladder muscle. What about overflow incontinence? So that's where the bladder fills and fills and fills with urine, and because of some kind of blockage, such as an enlarged prostate, the bladder never fully empties. So say somebody who's 80 years old and they have an enlarged prostate, they go to the washroom, they dribble a bit, they urinate maybe 100 milliliters of urine, but most of it never came out. It still stayed in the bladder. So then they fill again very quickly, and the bladder distends more and more. They dribble a bit, and it just goes on like this. So they always have a full bladder until they get to the point where the bladder valve at the bottom just can't hold all of this urine. They might have 1 liter in there or 1.5 liters. And finally, they're getting what's called overflow incontinence. It's like the bladder valve just can't hold the pressure that's in the pressure of the urine that's in the bladder. So it just starts to you just start to become incontinent. Okay, and often men will come in and say, I don't really understand what's going on, but I'm just dribbling all the time. And we put the ultrasound on their abdomen, and we see that their bladder is huge and filled with urine. Okay, and this is a perfect way to get a urine infection in a male, right? So BPH leading to overflow incontinence, or a very distended bladder, and now it becomes infected and they get a cystitis. Okay, what about a neurogenic bladder? So really this is a bladder that's had its sensory fibers disrupted that travel from the bladder to the spinal cord. Okay, and so now there's no ability for the brain to sense how full the bladder is. So it fills and fills and fills, and there's really no sensation of how it's filling by the patient because of the spinal cord injury. So these patients typically have to self-catheterize frequently every day because they don't have the sensation of how full their bladder is. And if they don't self-catheterize, what's going to happen is they're going to get recurrent infections because their bladder's always holding urine, or they're going to have chronic over-distension of the bladder, which could potentially harm the kidneys, because that is a form of post-renal acute kidney injury. Okay, so neurogenic bladder typically needs self-catheterization. Okay, overflow incontinence, by the way, someone who's just dribbling a bit, so an older man with BPH that's just dribbling a bit, well, they need something done with the prostate, right? So either a medication to help with the flow of the urine through the prostate, or a surgery to open up the prostate, prostatic urethra to improve flow so that they don't have chronic over-distension of the bladder. Functional incontinence is basically just really the inability to hold urine, usually due to some kind of brain disorder or psychiatric disorder. So someone who has dementia or delirium or say a stroke, where they're just not able to regulate emptying their bladder any longer. Often in dementia this happens, or someone who's been lying in bed for days or weeks. So that's more of a functional incontinence related to a CNS problem. And mixed incontinence is usually a combination of stress incontinence, meaning every time I cough, I leak a bit of urine, and when I'm walking down the street, I suddenly have the urge to go to the washroom as well. So they have what's called a mixed picture incontinence. Okay? All right, well, end of the module. I hope that was helpful. And if there's any questions, bring them up with your instructors. Ask them in the tutorials. Hopefully most of this will start to settle in and you can retain it for long-term understanding and not just memorization.